Yes. When the red light's on,
Okay.
it's on.
Okay.
And it's
Hi, ladies and gentlemen, can we please take our seats so we can get started with today's Public Health and Social Services Committee meeting? And could I just ask that all councillors please sign in? And at this time, I'll just make the announcement. Could you please turn off your PDA cell phones, put them on vibrate, please, and thank you. And we'll get started in about 20 seconds. Thank you. I'd like to call this meeting to order and ask everyone to please turn their electronic devices to silent or vibrate mode. As I said earlier, councillors, please ensure that you are properly signed into the system. Excuse me. Are there any disclosures of pecuniary interest? I see Councillor Gale.
Thank you, Chair. I have one on item 5.2, the long-term annual report. My daughter-in-law works there. Thanks.
5.2, sir, is that what you said?
Yes.
Okay, very good. Is there any other? Okay, we have a few presentations today. A member put forward a motion for Mr. Stephen Seuss to appear as a delegate. Councillor Diodati, please.
Yes, Chair, I'd like to put a motion forward that we have him speak. Maybe we might have him first up before we have the next presentations from the ladies.
Okay, very good. Do you have a seconder for that? Councillor Marshall? All in favor? And that is carried. Thank you. Mr. Seuss, would you like to take the podium, please, sir? How much is the time? 5 minutes, 10 minutes? Mr. Seuss, although there is no time limit, do you think you could do it in 5 minutes or 10 minutes, sir? Okay, very good. That's what I wanted to hear.
All right.
Good afternoon. How are you?
I'm good. How are you guys?
Thank you. Good, thank you.
So, the opioid crisis is taking over Niagara. We've seen in the paper that we're second in ER visits for the opioids, and so a lot of regional officials and a lot of regional personnel, they're asking for strategies and a solution to this. So I kind of jotted down some ideas that we could, take into consideration. I know no motion will go forward here today, but, a receipt for information, of course. So when I was reading, on Twitter, I seen the city of Hamilton was doing a day of awareness for opioids. And they were having people who were directly affected and supporters of those people and all that kind of stuff, come forward and gather and, share their stories, talk about, what we can do to move forward. So a day of awareness is probably a very good idea. It's something that can be taken into consideration. It seems to be helping in Hamilton for as far as I know. But I've been thinking, and I would hope that staff would be open to investigating a partnership with the 4 school boards, Brock and Niagara, and public health, because it all starts with prevention and education. We want to get at the issue before it even starts, or we want to tackle it, in its prelude. So I think if public health were to, visit schools, visit campuses, and, share the dangers of opioids, I think it would be beneficial to people, who are struggling. And, a lot of families, they don't know how to tackle this. They want the help. Look at how many organizations in Niagara are backlogged and overlapped from this. CASIN, CMHA, Detox on Adams Street. They're dealing with so many issues at once. I'm a social service worker, so I see this on a regular basis where they're full all the time, because there's those underlying issues. Not only are they dealing with mental health, but they're dealing with the addiction on top of that, right? So oftentimes, you'll go to one organization and you'll be asking for help at that organization, and then they'll say, well, we don't do addiction, you have to go here. Or we don't do mental health, you have to go here. But they're all interconnected. So we need to definitely get in touch with the contacts at those organizations, such as the ones I mentioned, and we need to see how we can better help them and how we can get services, essential services, to the people in need for this. This is something that's plaguing the youth of Niagara. I've had friends, I've had personal friends, people I went to school with, who are dealing with addiction right now, and who have passed away from it. So, you know, it's something that knows no socioeconomic bounds. It can affect everybody. This isn't a one size fits all issue. So we need to definitely look at that. And healthcare services as well are directly correlated to this because, you know, when I came and spoke about the need for the, you know, more healthcare services, it's because of things like this. So, you know, I'm hoping that this partnership can be something that can be seriously looked into, day of action, day of awareness, you know, because we have to be equipped to deal with this, and we need to prioritize this. As Councillor Gale said, you can't just arrest your way out of this, nor can you just throw money at it and expect it to go away. So, you know, I want to just say, anybody dealing with this, they're loved. We need to help them. We need to give them a hand up, and we need to really get this solved before we see more deaths, before we see more people falling, you know. So I really hope you know, I'm willing to always discuss with public health too later on. If someone's open to talking to me, I'll definitely elaborate on it. But I don't want to take too much of your time, so I'm going to leave it there.
Very good. Mr. Seuss, thank you for your presentation. Members of council, is there any comments or questions? Seeing none at this time. Thank you so much for your presentation, sir. We will now move on to 4.1, Moms Stop the Harm, MSTH, and Opioid Crisis Attachment. Jennifer Johnston and Sandy Walker Tandardini, members of the Ontario Chamber of MSTH and Moms United and Mandated to Saving Drug Users, which is the acronym MUMSSDU. They have a delegation package is attached to the agenda item as PHSSC C11-2017. Ladies, welcome. I call you to the podium.
Thank you. First of all, I'd just like to say that's really good to follow because it sort of, yeah, it gives us a lot to work with, and we're coming kind of from the same place. I've never done this before, so I'm really nervous. I apologize. I'm probably just going to read. But in starting, I think it's really important to understand what drives addiction. So I'd like to start off with just a piece I found from Dr. Sam Snodgrass, who is an opioid addict himself in recovery, and I'm just going to read. So, understanding what drives addiction is a struggle. This is a powerful perspective that carries the ring of truth and understanding. The truth is she told is that when we are in addiction, the things we do are not because we choose to do them and because we have to do them. Opioid addiction is survival, and survival is not a choice. Let's say you haven't had anything to eat for 4 or 5 days. You are starving. Can you feel it? What it's like to be really starving? What would you be thinking about? Food. You would be needing, craving food. This craving that you feel, that's the brain's mechanism that drives you to survive. Its purpose is to make everything else fall away and to force you to focus solely on attaining what you have to live. Now let's go further. Let's say that food is restricted. There's a famine or some kind of government control that limits the amount of food. There are no soup kitchens, there are no food banks, and no one will give you any food because they don't have enough for themselves. There is, however, a black market in food, but the food in this black market, it is scarce and it is expensive, and it is illegal. It is against the law to buy food in this black market. What would you do if you were starving? Would you break the law? Would you steal to eat and to live? How much of yourself would you sacrifice? How much of who you are, what you are, would you let go of to survive? This craving for food is measured in days. Our craving for opioids is measured in hours. 4 to 5 hours after our last use, we begin to starve, and we crave. 3 or 4 times a day, we experience this craving. Everything but our need for these opioids falls away, and we focus solely on what we have to do to survive. We don't have a choice. We really don't. Please understand, I'm not trying to excuse our behavior. I am, though, trying to help you understand why we do these things. I know it may be difficult to believe if we have stolen from you, if we have been verbally abusive, and maybe even physical with you, that even while we were doing these things, we loved you. When we hurt you, we hurt too. We are doing these things because we have to survive, not because we want to do them. we become desperate. And in our desperation, we do things that we know are wrong. We do things that we know are not us. But this doesn't mean we don't care. It doesn't mean we don't love. What it does mean is that we are starving and that we are so desperate that we will hurt the ones we love to end that starvation. What is sad is that we don't understand this. We don't understand why we are hurting the ones we love. And because we don't understand, we can't explain it to you. We can't explain why we are hurting, not to ourselves and not to you. No one told us that these opioids cause changes in brain structure such that they become more important for our survival than food. We don't understand this, and neither do you. And this lack of understanding can rip apart a family. It can replace love with resentments and anger on both sides. And in this pain, in this lack of understanding, we can lose each other. The knowledge that I have, that I hope you take away from this post, is that your child or your loved one did not hurt you so that they could go out and buy hydros, oxys, or heroin. What they bought was their survival. For those of you that have come to, Dr. Snodgrass runs a group called GRASP, and others in this group that have lost a child or loved one to overdose and addiction. I hope this post will help you to understand that there is no blame here. Whatever you did, however you tried to help the ones you loved, you did your best. That's because that's what love does. And I hope you understand that your child, your loved one, they did their best. They fought, they struggled, they did all they could to stop. But ultimately, this disorder took their life. Understanding, knowledge is power. The lack of it is confusion and helplessness. My son Scott was born on March 22nd, 1988. My son Scott died on August 27th, 2016. Scott was a beautiful young man. He was a trained chef. He was an athlete. He was a small business owner, and he loved the outdoors. He ran marathons and competed in CrossFit competitions. He hiked the mountains out west, and he was an avid skier. He loved his family. At one time, he owned his own home, had a beautiful fiance, and a bright future. We did everything the way we thought we should to raise healthy, happy, well-adjusted children. We were far from perfect. I was a stay-at-home mom until my children were all in school full-time and settled, and then I went back to school. I volunteered at their school, started a chess club, was part of the parent-teacher council. Scott's dad, John, worked early mornings and was home when they came home from school. Scott took karate, played hockey, and took swimming lessons. We have been married for almost 32 years. But he was a substance user, an addict. And like a lot of people who overdose on drugs tainted with fentanyl, the same can't be said for Scott. Fentanyl was his drug of choice, and he lost it all. He was a son, a grandson, a brother to Colin and Leanne, and an uncle to Jade, a cousin and a friend. He was my middle son, but he is also your son, your nephew, your niece, the child of your neighbor, the child of your colleagues. He is just one face of many substance users who have lost their battle with addiction, and his life mattered. He fought hard. He attended a treatment program in Calgary called 1835 after attending multiple treatment programs here in Ontario. Excuse me. He celebrated 21 beautiful months of abstinence out west. We went to visit him. He came home to visit us. We communicated almost daily. He came home to pick up his car, and he and his dad went on a road trip to take it back to Calgary. Calgary had become his home. And then he relapsed and faced about 9 months of substance use. He finally entered Claire's Home, a dual diagnosis treatment program where addiction is treated twofold. It treats the addiction itself as well as the mental health side issues. Scott was in pain emotionally. When he used drugs, all his anxieties and worries slipped away. We are only beginning to touch the tip of the iceberg in understanding that addiction is a mental health issue and the gravity of the problem. We truly thought he was on his way to recover. On August 26, 2016, he was released. His last text message to me that morning was that I should call him later in the day, to which I replied, and he never responded. 4 hours later, a police officer attended our home to inform John that Scott was gone. I was hosting a dog training seminar in Milton. John drove to Milton after waiting several agonizing hours to tell me in person. My family's world was changed forever. I refused to identify him from a photograph, so we flew out west 2 days later. All I could think of was that they had made a mistake. Since that horrible day, a day when my heart shattered and everything I thought I knew and believed changed forever, I have struggled to make sense of it. How could a child who would call me crying after difficult days, tearing himself apart, examining how he got to the place he was at in his life, relapse? I have struggled to answer this every single day. It was an answer I needed in order to be able to go on living without him. In my research, that's when I came across the article by Dr. Sam Snodgrass. It helped me to understand substance use and what drives addiction, because addiction to heroin and fentanyl are insidious. These are drugs this country has never battled before, and there is a good reason why Just Say No does not work. We are failing a whole generation, and they belong to all of us. I don't think I need to quote the statistics for you. You are probably better informed of them than I am. But in my research to understand, I began to realize that everything I thought I knew about drugs and substance use was wrong, and that we are only touching the tip of the iceberg, and that the information did not go far enough. Let's talk about 12-step recovery programs. The model of Alcoholics Anonymous is based on the model of Alcoholics Anonymous, and it is failing miserably. Having attended Al-Anon meetings, I can tell you that they talk about things like tough love and rock bottom. We should not be enablers to our family members. Tough love means withdrawing support. I could not do that. No matter what, I could not walk away from my son. And do you know what rock bottom is? What true rock bottom is? It's death. Every time I spoke to Scott, I told him that I loved him and would be there for him. I didn't have to like him to love him. That love never changes. The statistics for recovery through these programs are abysmal. Then we have our conventional treatment centers. Scott's been to many. He attended Port Colborne, Windsor, and North Bay, to name a few here. He availed himself of counseling and sponsors through NA. When Scott made a commitment to recovery, he committed with all he had. He did not want to be an addict. He wanted a good life. He had plans, which brings me back to Sam's article. He was set up to fail. We are only beginning to understand addiction to drugs like fentanyl and heroin. So I ask you, as a conscientious society, when is enough going to be enough? Do we wait for the numbers of deaths in the region to reach a certain number? In my immediate family, there are 23 members, including my siblings and their children. How many family members have to lose someone for us to act? As of June 17, 2017, there have been 209 suspected overdose deaths in the region. Look around you. That's 3 to 4 times the number of people in this room. What do we know? What we do know is that harm reduction works because it keeps substance users alive. A dead person cannot access treatment. A dead person has truly hit the only rock bottom there is no turning back from. Dr. Andrea Feller is Niagara Regional's Associate Medical Officer of Health. Dr. Feller herself has informed us that the number of opioid-related emergency department visits have increased 65% over the same time last year. How many of those could have been avoided if there were a safe injection site in the region? Dr. Feller stated that it is not clear if Niagara has the population density to be effective. Here is what I know about substance users. They are going to use regardless of how hard we try to stop them because they need to, and no one wants to die. I am reminded of the saying, if you build it, they will come. In my opinion, we are missing a huge opportunity by not having a safe injection site. When an addict decides to reach out for help, it is a very short window of time before that starvation kicks in and survival mode is entered. We have to be there for those opportunities with resources. But let's talk about the population density for a moment. Centennial Gardens is just around the corner from Positive Living Niagara, which is a community-based organization which clearly recognizes the issue in the region. It is also important to note they started as an HIV outreach clinic back when the stigma against AIDS was very real. Today, the stigma is very real regarding substance users. They already offer a needle exchange program. Fed Bowering is a private citizen who picks up needles at the park. He has been quoted as saying he sometimes finds dozens of needles a day. Park staff collect the needles as they see them. Clearly, we need to be doing more. To my extreme disappointment, no application has been submitted for a safe injection site, even though it is obvious there is a high concentration of substance users just in this one area alone. Today, the stigma is very real. We see it all the time. Someone on social media posts something about drugs, overdose, or harm reduction, and there inevitably will be those who say things like, let the druggie die, they brought it on themselves, or they made their choice. This is the only disease we do this for, and it's beyond my understanding. When a smoker develops cancer, do we refer to them as a nicotine addict, or someone overweight develops diabetes or heart disease, do we call them a food addict? We treat them with kindness and compassion. We hold fundraisers, we have support groups, and we employ the best treatment options money can buy. Not so with those addicted to drugs. I will make no secret about the fact that I support, at the very least, decriminalization of drugs on a federal level. But that's a topic for another day. We know that we know from Dr. João Guleo, Portugal's National Director of Drug Strategy, that decriminalization works. How many of us have actually witnessed firsthand what our programs look like? How many have attended drug treatment court to see exactly what the treatment programs look like? I have. It is ineffective for a reason. Health Canada recently decided to allow more access to prescription heroin to curb the crisis. To date, the only province to take advantage of this program is Vancouver. Why? Because the restrictions are so great, they do not allow for adjustments and judgments. We don't even trust our frontline doctors and workers. What about Dilaudid? This is proving extremely successful in Vancouver's Portland Hotel Society and is allowing frontline workers to treat the patients and meet their needs. I hope I live long enough to see the day these treatments become the norm. Combined with treatment, support, counseling, and appropriate drug therapies, lives can be saved. But the conversations continue, and while we talk, they die. Thank you.
Thank you, ma'am, for that presentation. You are Mrs. Jennifer Johnston, correct?
Yes.
Oh, okay.
Okay. Good afternoon, ladies and gentlemen. My name is Jennifer Johnston, and I'm here with these other beautiful souls, all of us sisters, bonded not by blood, but by life's greatest tragedy. We have all lost our beloved child, specifically to opioids. Opioids, that scourge of society which has devastated our country for years. Now, with the onset of fentanyl, we are in a massive epidemic with thousands dying every year. Wilma lost her beautiful Jana at age 19. An outgoing, vivacious college student, she was adventure-loving and had the innate ability to light up any room with her presence. Her family, including mom, 2 sisters, and a brother, miss her very deeply. Wilma and I met in a grief group and were astonished that of 7 in the group, 3 were from overdose. How could that be? Such a grim statistic. Judith Rossman's son Noah was a gentle soul, beleaguered by his peers' unacceptance when his mother first asked him why he was doing drugs in high school. His reply was, "Mom, it's better to be known as a druggie than to be known as that gay guy." How sad is that? Ann Miners lost her only child, John, at age 27 in November 2016. Pardon me for a moment, I just needed to. He was the apple of her eye. For those of you who are parents, I ask you this. Imagine being a parent one day and then bam, all gone, no chance of a grandchild, your whole future irrevocably altered. This is her sad reality now. And of course, you already know about Sandy's son, Scott. My eldest child, Jonathan, was 25 and a successful chef when he collapsed on a dirty Toronto sidewalk at 3:23 a.m. on April 20th, 2016. Accidental overdose, the police and coroner informed me. Fentanyl poisoning, I call it now. He took his usual hit, and unfortunately the heroin he assumed he was taking was instead 99% fentanyl. Never in 1 million years did I think this could happen to my intelligent, intuitive, charming, success-driven son. He had left home at age 18 to pursue his dreams of becoming a world-class chef. At the time, he was just doing just that at Origin Restaurant in Toronto. His nickname was 5-Star, and it suited him so well. He was the greatest big brother to my 4 other children and a stepbrother and sister. In the devastating months since, I have turned my eyes to advocacy. How could I not, after looking into the eyes of the hundreds of lost ones I see every day? Today, these ladies and myself implore you to move forward with the many radical steps. And yes, we know they are radical, but we need to do this or an entire generation is going to be decimated. Do you really want to wait till it's your niece or your nephew or, God forbid, your child? Our kids are dying in droves, some as young as 14. We've all seen the news stories: death, destruction, chaos, shattered families nationwide. Unfortunately, we've also noticed the other stories, those highlighting government inaction. From governing bodies, we see much talking about it, but very little action. It could be said that if these deaths were from anything other than SUD, much more would have been done long before now. This is beyond frustrating to us. The Ontario government should have heeded the warning years ago from our neighbors out west. We ignored them, and here we are, neck deep in an epidemic of massive proportions. Why, we wonder? Why has our Prime Minister not declared a public health emergency? Why do we not have an SIS in every community? Why are substance users not offered an immediate long-term solution when they reach out to a doctor for help? Why is there not any public awareness campaign decrying stigma? Why are we not offering prescription heroin to SUD patients? Why are we not supplying naloxone kits to every school in Canada? I'll tell you why. Most people who see that young girl prostituting on Gale Crescent, they see her as a loser junkie. It is only when this tragedy strikes within your own circle that you see her as somebody's daughter, somebody with hopes and dreams, someone who suffered trauma as a child and eases that trauma with drugs. Could we please step up and lend a helping hand? What will become of us as a society if we do not create a loving, non-judgmental environment where these broken human beings can find a connection to hope, a connection to healing, a lifeline leading to a joyful, productive future? For an investment now, we will see untold benefits and long-term savings. Our lost children are beyond help, but for myriads of others, there should be hope. Please help bring them hope. Use us, use our stories. Within each and every one of our tragedies lies a piece of the puzzle. In hindsight, we see what went wrong with eyes full of bloody tears. Maybe Jonathan would be alive today if the police and paramedics carried naloxone when they tended to him. Maybe he would be alive today if the doctor he went to begging for help hadn't merely offered him a prescription of Percocet and a handful of bad advice. Maybe, just maybe. In closing, we would like to offer ourselves and our oh so sad stories as an example of what not to do. Use us, please. Let's save some lives. Thank you.
Jennifer, Sandy, thank you for your presentation. I'm going to open up the floor to some questions and comments, but take a few minutes to just compose yourself. Perhaps maybe you might want to introduce the three ladies to your right that have come here today too as well, or if they would just like to stand up and introduce themselves. You don't have to come to the podium, just thank you.
I'm Judith Rossman. I lost my son Noah 5 years ago.
This is Noah.
He was a week shy of his 22nd birthday. He was a Brock student. He was a productive member of society. But it just didn't work for him.
Thank you.
I'm Ann Minus. I lost my son John Carrigan on November the 13th, 2016. And my life has been altered completely. My name is Wilma Thompson. I lost my daughter Jana Thompson, 2016. She went to Fleming College. She was going to become an environmental technician. She wanted to stay ahead. And unfortunately, she met somebody there, and that person introduced her to off-season fentanyl, and she never came home.
Thank you. Thank you. Judith, Ann, Wilma. Jennifer, Sandy, thank you so much for telling us your story today. I know it's heart-wrenching to stand up and do that. I will take this time now to open it up to the floor if there's any questions or comments from I have Chair Caslin up first, please.
Thank you.
Councilor Volpatti.
Yes, thank you very much for being here. It's heart-wrenching to hear the stories, but from personal experience with a child in need, I have been told, and I know it's very effective, there's nothing that's more effective than a mother's story. A mother's story can change the world. You are 5 mothers, and there are many others like you out there. So thank you once again for being here, and I hope that you can achieve at least some of why you came. Thank you.
Thank you, Chair Caslin.
Thank you, Mr. Chair. When I pushed the button, a lot of the questions had not been answered, but subsequently have been answered. So thank you for your presentation today. You obviously are not, you think that there is a lot more that could be done in this particular instance with a lot of different agencies. You mentioned the federal government, you maybe mentioned others. I guess my question to you as Niagara Region, which we are here today, what advice do you have? I mean, Niagara Public Health has already acknowledged that the problem is getting worse. What advice do you have for, not the federal government, not the provincial government, Niagara Region Public Health, because they're here listening today? What advice do you have for them specifically?
Well, I actually researched that to see, because you can go on the Health Canada website to see who has made applications for safe injection sites. And as of last week, we have not even made an application. And I think the first step has to be the application. It's my understanding that when an application is made, a site does not have to be designated. So we can make the application, which we all know there's a lot of red tape. It can take 6 months to probably longer, and probably a year before that application is even approved. So I fail to understand why that first step hasn't even been taken, regardless of whether or not we find an appropriate site where the density supports it, the volunteers supports it. That to me is the first step. And that can be done within the region, regardless of what the provincial or the federal government, whether or not they declare a national emergency and provide the additional funds.
In addition to that, are there any other recommendations that you would like public health to hear that you feel would be part of their strategy, should be part of their strategy?
Yes, I think that we've been to Moss Park, and I work in Hamilton in the criminal courts, so I've seen the drug treatment court. We went to Moss Park to visit where they have the pop-up tent. Ideally, we would like to open a pop-up tent. We realize that it's not doable for us. We're just 2 women. We just don't have the resources to do that. We don't have the time. We don't have the backing of the community. But it is a start. I mean, if that's something that the region is willing, the problem is they're obviously unsanctioned, right? But I think that the biggest thing we can do is, at this point, look at some sort of anti-stigma campaign. I think we need to get the message out there that, we're all 5 women. We met on a fluke, and we all live in the Niagara region. There's got to be dozens of us out there. There's people in their homes that, are lost, they're desperate, they don't know what to do. People before they become us who've lost children. I think anti-stigma campaigns and vigorous campaigns in all the right places may have a huge benefit, because we can provide links. So, it's information packages. It's like a sheet of paper that you find at every pharmacy, every doctor's office, every walk-in clinic, where someone can discreetly say, that applies to me, take it, there's resources, you know, and link them up to the resources that are in the Niagara region. But the anti-stigma, people have to stop thinking of these children. I mean, they're children to us, but they were, you know, they were grown men and women, as, you know, that druggie, you know, you know, I mean, we've heard some horrible things. You post things on social media, you hear horrible things, let them die, you know, who cares?
I heard last week, oh, give them naloxone, just kick them at on the head and move on.
Yeah.
That's what I heard.
Yeah. So we need, just like we did with AIDS, we need to start educating people. This is not a punishment. Death is not a punishment. You know, this is something we need to understand, and we're only just beginning, you know, to understand it. And
It's safe to say that we've heard enough talking, we've heard enough statistics.
absolutely.
It's time to get moving.
Absolutely.
It's time to develop a plan.
Yeah.
Thank you for your
Absolutely.
advocacy.
There's
Thank
5
you.
women here who will sit on any committee
Yep.
and help write documents.
Mm-hmm.
Whatever you need, the 5 of us are there.
Yeah, we're volunteering our
We're
services for
very, very
anything.
willing to be
Speaking
part of that.
speaking at high schools, whatever, like it all needs to be done.
Yeah. Hopefully we'll get better at it as we go along, but.
Well, you're talking about me, not
This is-
you. You're good.
This is our first, so we are a little nervous, and, you know, we didn't want to bombard you with statistics because, like I say, you guys know all the statistics. Everybody knows.
It's in the news every day.
Yeah, you can Google it and find out 1,000 different statistics. We don't need more statistics. We need to start acting on those statistics.
I think you're right, and
Yeah.
I think we do need to start acting.
Yes.
Thank you.
Yes, I really appreciate that. Thank you.
Thank you, Chair.
Thank you.
Councillor Beatty?
Yeah, thank you, ladies, for your presentation. Very, very telling in terms of the true story.
Thank you.
I'd like some background, if I could, maybe from Dr. Yeager, in terms of naloxone. The nature of that, does it work on all people who ingested or taken drugs? Can it be self-administered? Could it be
No,
provided?
they
Is there
usually
a
by
large?
the time they overdose, they're not lucid enough to do it for themselves.
Don't have the motor function, okay.
Yeah, sorry, it wasn't really directed at us.
No, that's okay. For example, do our paramedics have it available in our ambulances and so on? Could we just get some background on the nature of that, the cost of that drug?
Dr. Yeager, please.
Thank you, Chair, through you. And first of all, sincere thank you for coming to speak to us. I know one of you used the phrase, it's just one face, but we absolutely know that everyone has a face. Right? We may not know who the mother is, but every victim did have a mother or has a mother.
And a
for sure.
father.
And a father and friends. And
Yeah.
so thank you for bringing that right here into this chamber. To the council's question, the naloxone kit, which is distributed, is a cost of slightly under $50, which is really not that much. Naloxone itself does work against any opioid, so not just fentanyl, but anything in that family. Naloxone has a shorter time of action, unfortunately, than the other opioids. So by that I mean if somebody's administered naloxone, it will wear off. Naloxone can wear off and the other opioid is still acting, which is why we've had a big push, and we actually see results in this piece, to don't just run away if you're in a group, call 911, and then if you feel you have to leave the person that's administered naloxone, call 911, because naloxone will buy about 10 minutes. It is administered to the person is absolutely correct. By the time a person is in an overdose situation, they're not thinking that way, and they're not necessarily capable of undoing zippers and accessing the medication that they need. But it is the same as an allergy nasal spray now. You stick it in a nose, nostril, squeeze the bottle. And each kit comes with 2 of those. I will share with this group, since it's on the naloxone, that certainly one of our goals is that I think naloxone, because it needs to be used so quickly, needs to be in many, many, many places. Just like we've tried to put AEDs in many, many places, these need to be even closer at hand because you have even less minutes. We presented to all of the principals at the Niagara Catholic District School Board last week, and they will be, I think, placing one in each of, following discussions with their board, et cetera, and following teaching from our staff on use, they will be placing in each of their schools. But also importantly, they will be sending out to all of their students that these are the signs. This is what you should do. This is what you should know. And if this applies to you, please know that you can go to over 60 pharmacies in Niagara now, and you don't have to say it's me. You can say, I have a friend, or I know somebody who uses. Can I have a naloxone kit? And it will be distributed. So I fully agree with this piece on stigma, absolutely. Because to your wonderful example, it's still illegal. And even if we certainly are looking at this possibility in terms of a supervised site, we want people to feel that they can come. So whether it's a supervised site, or whether it's Quest, or whether it's an individual doctor's office, or whether it's whatever the location is, we need people to feel that if they need it, they can come. And that's part of it.
I'd just actually like to,
And our paramedics absolutely have it on every ambulance.
I actually received naloxone training through my pharmacy I live in Beamsville, and they aren't providing the nasal. They're only providing the injectable. And the number one rule that we tell addicts is never use alone, because the chances of them, Scott had in his presence a naloxone kit. He never had a chance to use it.
So my understanding is that we're in the process of changing over from the old supply, which is injectable, to the new version, which is nasal.
Yes, perfect.
Councilor Beatty, you still have the floor.
Just could ask the chair of the police services board as well to bring up that discussion with regard to the other first responders and fire. It seems to me that that's one of the courses of action that needs to be undertaken. More awareness of where you can get access to these kits. I would agree that the nasal ingestion is far better than the needle injection. It makes sense. And that's one, of course, not the only course of action, but I think it's one of the courses of action that should be pursued, given what you've indicated the cost factors are. Okay, thank you.
Okay. Councilor Diodati.
Thank you, Chair. First of all, thank you. I know this was not easy. Probably the worst thing ever is a parent losing a child. Unthinkable. So first off, thank you for doing what you did. You know, you had a choice. You could have just been sad and turtled, and you did beyond that. You spread out to make a difference, and I think that's a huge step, and you're to be commended for what you're doing. You took the difficult road, but I think the most effective road that's going to actually make a difference. And I'm hearing all the discussions about administering this and whatnot. I think what we need is not just to look at the cure, but the prevention at the beginning, and not just at high school. One of my brothers is a police officer, actually both my brothers, and one is in Toronto, and he's a community police officer, and he goes into all the schools. And he said, by the time you're in the high school, it's too late. They know everything.
That's right.
And they're not listening. And I think what we need is an all-out massive approach, and I think we need a coordinator, a QB. And I'm going to make a motion that public health be the quarterback to coordinate all the essential services, police, EMS, us, public health, the school boards. There has to be a lead, there has to be a captain, there has to be a quarterback. We had a problem in the city of Niagara Falls with coyotes, and we didn't know whose fault it was, so nothing was getting done. We brought everyone in one room, came up with a coordinated approach, and that's what we need. I think that obviously it's about awareness and education. I can tell you, I've been ringing this bell for years here. I've been sending emails for years because I saw the trajectory, and all these drugs start out west for some reason and come east. And the doctor will tell you, I know I've been sending a number of emails. What are we doing? What are we doing? It's here now, and it's not like we didn't know it was coming. We saw it coming.
Yep.
And it's the trajectory. It's not the amount of deaths, it's the trajectory. You see where it's going. It's growing exponentially. So what are we going to do about it? And I can tell you, in my house, I've got 3 kids, 2 teenagers, and we have a discussion because of it. He said the fact that when I put it into simple, bite-sized pieces, sound bites that they can register, I tell them, you know, 2 grains of salt worth of fentanyl is enough to kill me, a grown man. And I said, you don't know when you go to these parties. You don't know what you're smoking. You don't know what the kids are injecting, what you're drinking. You don't know. It's
pill.
Russian.
Could be a pill.
It could be anything. It's Russian roulette. And some of the games they play with the prescription drugs, and everyone grabs a handful, and you see what happens is ridiculous and irresponsible. And so my kids, before they knew it all, they know now, and they're very fearful of it. And I know with me, I was always too afraid to try anything as crazy as these kids today. My parents pounded it into me. But I believe that here, this group, we can start with the prevention, get into them early enough with education and awareness, coordinated attack, and investments can take money. We got to get into those classrooms. We have to have someone designated that can communicate the message. Never mind the science, just real life stories. These stories that you're sharing with us here, that makes it real. That hits me right in the heart, and that's the thing that I always dread. It's always a story about my kid was a typical kid, and I don't know what happened, and a lot of time it's the kids they hang around. So many outside forces against our kids. It has got to be one of the toughest things that we have to deal with. And so, Chair, when the time is right, and I know there's more people that want to talk about this issue, I'd like to bring forward a motion that public health quarterback this issue with all the other essential services in the region, and we can be an example for the rest of the country. We don't need to just look at what's being done. We can start the trend right here and make a difference. Yeah. So when that time comes, I'm happy to do that, Chair. Thank you.
And I also too, I just like to address sort of what you said. I did the same thing with my kids. I was part of the, you know, Just Say No drug campaign. That doesn't protect kids. You know, we can beat it into them, but there's always that, you know, you have a 14-year-old kid, they're invincible. You know, they think, I mean, up until the end, Scott told me that people who overdose on drugs don't know what they're doing. That's the reason they overdose. That's the mentality of what the addiction has caused. So even children who are educated, and we talk to them about this openly, in a moment of weakness can have that lapse in judgment. No one is protected. No one is protected. You know, and like I say, I had those conversations with my kids. I don't do drugs. You know, I didn't want my kids doing drugs. I mean, when I found out my kids my son was doing fentanyl, I'm like, and he was doing it long before it was a thing. You know, I'm like, fentanyl, because I worked in a vet hospital for many years, and I'm like, that's a pain patch that we put on dogs after massive surgeries. Like, what are you doing with it? Like, what you learn about it unwillingly is huge. And I think that part of your strategy has to be accepting that there will be those kids, regardless of whether, you know, the Just Say No campaign, education part is there. There are those kids that will take that risk, because kids are risk takers and they know everything, you know. So I think that has to be included and realized that alone will not stop the deaths, you know.
Thank you, Sandy. Councillor, you have the floor still. Good. Councillor Rigby.
Thank you, Mr. Chair. And I had 2 or 3 questions, but I think they have pretty much been addressed at this point, and I'd like to take the opportunity to second Councillor Diodati's motion when he comes to it, if I may. I'd like to say to you, I know the heartache what it feels like when you lose a child. Unfortunately for you, but fortunately for me, he was older enough, and we do have 3 grandchildren. And that is huge, and the feeling you have as you go through that journey. And I can't imagine what it's like when you see it happening and you can't stop it. And I just thank you so much for being here. And I might say, because Mr. Seuss addressed you first, and I did try to stop him from coming. But I'm glad he did, because he was talking about
you know, addressing some of the issues that we need to work together. And so I think that it was a good message. I apologize to him. But I think I certainly, if I understand Councillor Diodati's motion, I think that is a step in the right direction. And I hope I'm right. Thank you.
Thank you.
Thank you, Councillor. Councillor Gale.
Thank you, Chair, and through you, thank you for your presentation. Did you watch or were you here a month ago, or September 5th, I believe it was, when the doctor talked about opioids?
No.
Okay,
No.
at that time, I'm chair of the police board. For the last 4 or 5 months, a lot newer than what you've been through.
Okay.
I've heard that opioids going to take us over. We hired a new deputy chief who came in from the RCMP in Vancouver, and I think I had the stats then of how many people were passing away during the year on that. And I said that it's adults through the kids. I get it on this stuff. And I've often said for many years that if you ever want to solve a war, get the mothers who've lost kids together and get them talking, it'll solve the war. But regardless of that, while you were talking, I just sent through the chief of police, and this goes hand in hand with what Mayor Diodati's saying with motion. And so here's my text that I just sent to the chief of police. I put down, Brian, we have 5 mothers at public health meeting who are from the region and have all lost children to opioids. I'm going to ask, geez, you just sent another one. I'm going to ask them to come to PSB Police Service Board and state their stories on Thursday, and then set up a meeting with you, Bill, or Brett, our deputy chiefs, as to plan for clinics for the anti-drug, etc. We will donate to this as a police service board. Okay with you? They are pleading with us. He sent back, sure. Sounds good to me, recognizing this is a public health issue, but we can certainly play a role in education. And I sent back, yup, I will suggest we get public health there too. Then Mayor Diodati started talking, and I put down Mayor Diodati's on this right now. We recognize it's a public health issue, but we need you involved on something like this, because we're government, we're slow in that. I'm knocking me as much as I knock everybody in government.
I work for
throughout.
government too. I completely
But
understand.
you have to cut to the
Yeah.
chase on this, and that's where we're gonna
Yes.
need your volunteer time on this thing.
Certainly,
So Mayor Diodati's gonna make a motion, public health will
Okay.
get behind it. But you have to keep talking like you are.
Yeah.
And you have to control your emotions. I'm sorry to be critical,
know,
but no, I'm
and
not knocking you.
I had-
I'm just saying that we gotta use up here on this stuff. What's
I
the best
know.
way for it? Because if you know what I mean by that, on that. So, and from a police service board, we donate to a lot of causes. Damn it, we should donate to this.
Absolutely.
On this, and I can get businesses to donate, but education is everything on this. And like I said, and somebody used my line, and I didn't originate it, we can't arrest our way out of this. We know that. We know it's from adults to whatever. So please, I support Mayor Diodati's motion on this, but we've got to get moving on this right away, because our budgets are going to, and I'm sorry to talk harshly about money, but our budgets are going to go through the roof on everything here, because we're not going to solve this unless we do education on this type of stuff. And I don't know where to go on this, but you have a better chance with this, so I support your motion on it. Thank you.
Thank you.
How do we get to the police that you said that?
In a heartbeat, I can have you there. We're on Thursday, but let's see how this motion goes. And if you want to talk to the police, I wouldn't bother right now, because they all get it. I'll play this tape back to them.
Okay.
And that, but I'll get the police to the meeting that Mayor Diodati's setting up. I hope you're setting up a meeting with us with public health, because they all know this. We've been to enough lectures. I said at the last meeting, I was in Brantford, and it's amazing how this is taking over everybody. And we know it's going to be worse all the time.
We'll be there wherever
But
you
you're
tell us,
5
we'll
people
be
from
there.
the Niagara region. You hit home with this, and you have pictures, and that makes it personal to us. So, if you want the police, call me, call anybody here. We'll get the police involved, but, it's not just police. It's the education factor. Okay, thanks.
Wonderful.
Thank you, Councillor Gale. Councillor Marshall.
Thank you, Mr. Chair, and thank you, ladies. Excuse me. I appreciate very much your presentation. And as Councillor Gale said, we talked about this just a month ago, but it has a different flavor today, and I think your attendance means a lot in terms of how we approach it. There's times when you don't want to be too emotional, when you're trying to be clinical and scientific. At the same time, pictures like this, I can't imagine your loss. I don't even want to talk about it because I don't know how long I could talk. But my questions are largely for staff, and I'm certainly going to support Councillor Diodati's motion. I look forward to that. And we talked about these very things a month ago, and we were in a direction, we all knew that it's coming. And we didn't want to wait. That was the theme of the meeting, really. Why wait till it's a crisis or a problem? 2 or 3 weeks later, we find out it's a crisis. Now, I don't understand that. The statistics that were presented, an excellent presentation by our doctor, and his name fails me right now.
Dr. Feller?
Yeah,
Virgin,
and
sorry.
he was great, and we learned a lot from him. The statistics went up to last year, nothing was in this year, none was 2017. And then out comes the hospital, which I worked there for 35 years. And then that was sent and released. All of the provincial hospitals released their data. Then we found out it was a crisis, but it's September. You really can't wait from sometime in 2016 to more than halfway through 2017 to find out there's a crisis. Yeah. How many people died during that crisis? Because I hear about, oh, we're phasing out the needles. Why are we phasing anything out? Let's throw them away and get something that's more effective for everybody in terms of the naloxone. When we're in crisis, that's what happens. I wonder, and we're talking about this committee, and I hope, obviously, we'll have the police there, and we don't want to arrest. We don't want people to be frightened of the police. But if the police went somewhere and found out something's being cut with fentanyl, it could be marijuana, it could be cocaine, not another drug, and that becomes the problem. And you reference poison as opposed to an overdose, and you just don't know what's coming. There was something in the paper about a strip for fentanyl, for a test of fentanyl, and I'd like to ask our MOE about that, because that was intriguing. Can somebody go to a spot and say, no, you think you're smoking dope, you actually got fentanyl in your system?
Well, it's something good to have on hand at a safe injection site.
Well, I agree with the safe injection site that was specifically asked for. They said we could be as far as a year away in terms of study, and I appreciate you have to do studies. But during an emergency, some of those studies have to go by the way in order to be effective in a crisis. But if I could ask Dr. Yeager with respect to the strip and the implications of being able to use one.
Dr. Yeager?
So through you, Mr. Chair, so the fentanyl strip is something that identifies the existence of fentanyl. I think to some of the points that the mothers have made, which are absolutely right on in terms of starvation and need and filling their survival need, this is often not a situation where the individual person who has the need is going to use the equivalent of a glucose monitoring strip. So is it something that is better at something like a supervised consumption facility? Yes, or that's something that you may have on hand for your friend. It's another of these things which as an individual user could be challenging. It's also not that widely available yet.
Okay, and the reason I was asking that in the event that the police, because I don't want them to stop it by arrest, like that would just push people away. I want them to be able to identify clinically that fentanyl's in the neighborhood. We have a bad batch in Niagara, because it seems to hit community after community, and quite independent of each other, as soon as a bad batch comes in. And we have to identify that quick, not wait for 6 months to get hospital statistics or police statistics. There should be a part of our protocol for this committee. We should know within days that we have a problem in Niagara because of this fentanyl cut medication. And this is just one aspect of it, but I didn't want to lose that point. And I won't go on. We've discussed it. We will be discussing it again. I so much appreciate and impressed by your presentation, and it certainly brings a lot to the table, and I wish you well. Thank you.
So, councillors, thank you for your many comments and questions. In anticipation of Councillor Diodati's motion, our Chief Medical Officer of Health, Dr. Yeager, is asked to speak first.
So thank you very much, Chair, and thank you, Mayor Diodati and Councillor Rigby, for your support of this motion. I do want to say that there is in existence the Niagara Opioid Network, which was founded about a year ago, conjointly actually started with the then police chief. Deputy Chief 40 has joined that network. It is The network is co-chaired actually by Public Health. Amy Fishley is sitting over there. She's the co-chair of that network, along with Positive Living Niagara. We have invited Jennifer and the representatives from mums to serve on this network, and we're very happy that they've agreed to be part of that. So I think it's fair to say that this group is entering a new phase. It is already composed of about 20 community partners and is dividing itself into different work groups. There is a webinar from the Ministry of Health on Thursday morning on extra funding and how to apply for supervised consumption facilities. Certainly our staff will be on that webinar to hear about that. And the network itself is dividing into different work groups because we have heard about timelines. There's the immediacy timeline of naloxone. There's the longer term timeline of how can we persuade people not to turn to this? How can we persuade them to turn elsewhere? And then there's the more intermediate timeline of, I'm asking for help. Can you find me a counselor, not in 2 months, but perhaps tomorrow morning, and can you help me to hang on until that time? So we're dealing with a lot of different timelines, and so these are the type of things that the existing committee will want to look at. So I did want to inform council of the existence of this group and to ask, I think, the mover and seconder whether is that the kind of thing that you had in mind, with the understanding that it is stepping up its activities.
Thank you.
So, Councillor Diodati, you've heard the question from Dr. Yeager. I understand your motion. She has put forward what is out there now. Is that something that you would like to see stepped up? Or are you clear with what the direction this existing committee is doing with its group and its subgroups? Sir.
I think it's time to hit the refresh button and step it up, and maybe we got to rebrand this. Maybe we need a different kind of acronym for this group. I'm not sure, but I think that definitely this Niagara Opioid Network, coupled with what I'm suggesting in the motion, can come together. Sometimes when you put all these smart people in the same room, the right idea kind of bubbles to the surface. And I think the right idea is going to come out of this once they have, as long as they have a good facilitator and you know what your objectives are, I think it's going to come out of that meeting, and we'll come up with so what I'd like to do, if I could bring my motion forward now, Chair. My motion would read that Niagara Regional Public Health take the lead with a coordinated approach with all partners, including but not limited to Niagara Regional Police, Niagara Regional EMS, the school boards, the Niagara Opioid Network, the network of mums, mental health groups, and any other ones I've left off the list that should be included in this, that they gather with an all-out massive action approach to education, awareness, investment, knowing there'll be money involved, in addressing the prevention and cure strategies for this opioid crisis, and report back to this board, because we want to know what the plan is. So we plan the work, then we work the plan. We can follow this through. And I would hope that we would do that in consultation with some of our networks out west who have had years more experience than we have at this. And hopefully this would be the beginning of, or in addition to some of the approaches that we've had in a more stepped up fashion.
Okay.
I would move
you just gave the clerk's department a heart attack, so if you could just give that to them. I see them looking back here and going, we're not getting this. So they have it now. So Councillor McBee, you will second that. I'm asking the clerk's department to decipher it and put it up on the board for us for all to see. I will now be accepting comments or questions to the motion. So I see that your hand is up, Councillor Marshall. I'll let you go first.
Just to ask for Niagara Health, I'm sure just an oversight. But if Niagara Health could be included in the motion itself?
Niagara Health and NHS, absolutely. So that's why I said, but not limited to, because I know there's a lot I've left out. I just want to get the ball rolling. Yep.
Okay. Any other comments, questions, amendments, Chair?
Yeah, I just will add that we recently had a symposium in this chamber, and we had a collection of professionals from all different walks of the medical field. And Dr. Yeager will know better than I where they came from, but I can tell you that there was representatives from pharmacy as well, and they had a lot to say, and as well as all of our EMS and the people that were named. So there is a variety of people that are collected together and are focused on this issue. And I'm not sure if we're talking about the same group or not.
Dr. Yeager.
Through you, Mr. Chair, yes, we are. And so Mayor Diodati has provided a list of very appropriate people. All those groups are currently represented on the opioid network, with the exception of the mums, who are now the latest addition. But it is that group to which we did invite the mayors to come a while back.
Yeah, I didn't want to miss the opportunity to recognize that there is a group that continues to work and has been working on this. Despite what's happening in our community, they are putting forward best efforts.
Okay, thank you, Chair. I do have Councillor D'Angelo, and then I'll go to Councillor Gale. Councillor D'Angelo, please.
Oh, thank you, Mr. Chair. Yes, I'll be supporting this motion. Just the question that I have regarding the motion was, it talked about a plan coming back to the Board of Health here. I'm agreeable with that. That's not a problem. But I think we also need updates as we move along to make sure that we're informed. And are these meetings going to be open to the public? Because there may be others that may be able to aid in moving this forward. As Councillor Diodati mentioned, not listing all of them, but will be an opportunity for those that may be interested in helping and offer helpful advice along the way to be participating? Or is it just going to be the group and they'll meet, I don't want to say behind closed doors, but just without public knowledge?
I guess I need to ask the mover and the seconder that, and so I'll just wait for Councillor Diodati to finish with the clerks, and then we'll ask him that.
Well, I guess maybe the past network that was moving, was there minutes coming back to the Board of Health here regarding what was happening with those meetings? Again, it's great to have meetings, but I think they need to be reported back and to make sure that the focus is moving forward constantly, that we're trying to achieve a goal. Because you got meetings for the sake of having meetings and it delays the process, but you have to have the goal to move forward. So just clarity on that.
So Dr. Yeager, this symposium, was there a chance that there was going to be meetings coming back to the public health meeting? Or what was the outcome?
So through you, Mr. Chair, so the network that was established, as I said, was originally established at the invitation of the Niagara Regional Police. So it is not per se a public health domain. It is a collection of almost anybody you can imagine across Niagara coming together. However, that being said, there is a responsibility in terms of public health now to manage this and to perhaps increase the direction. We certainly will provide repeated updates to council as things evolve and what the plans are, and keep council updated on developments and the progress of the committee. In terms of it being open to the public is more than welcome, and we will find a way through our website or other means to receive input and suggestions. Not just from the number of people, but just in order, because as things go on, people are in different phases and there will be different work groups. And work groups by their nature do not lend themselves particularly well to people watching and necessarily at that time making input at the time of the meeting. But there's nothing secretive about the meetings. There is nothing, that the public will not be informed about. Absolutely. This is a public issue. This is not something that 20 people sitting around a table are going to solve. This will require buy-in and the tentacles to spread throughout our society in order to get even a small handle on this.
Just supplementary comments, and yeah, no, I appreciate the comment there, and I know when you're in a working group, work has to get done. I appreciate that. It's just that we want to make sure the public's aware of how this is progressing, what's being done, and if there's anyone out there that does have an opportunity to maybe participate in one of those working groups to make sure that this has moved along quicker, that's what I was trying to get at, and it sounds like that's going to be encompassed in it, so I'm quite happy with that. Thank you.
Thank you, Councillor. Councillor Gale for a second time, then Councillor Marshall.
Thank you, Chair. So I'm speaking to the presenters again. We need them on this board, or at least some of you on this board. And you're going to get discouraged because this is government. but you can't let that take you over. But you have to report back to us if it happens, because there's red tape. But we're all gonna be looking for a goal to try and stop this. And that's probably, might be a pipe dream, but like try our best to try and stop it. So don't get discouraged and walk away, because this is, we'd all be walking away from this council real quick, or any government position we have. So give your input, and please bear with us on trying to solve this. The police are behind you. If you find that any organization that's in here isn't behind you or supporting on this, we're all united on this. Maybe I'm giving a bit of a lecture now, but please don't get disheartened. Do whatever you can to get on it, and if there's a problem with the police or a problem with anything here, let us know, okay? Thanks.
Thank you, Councillor Galen. Can I ask you please to coordinate with Mr. Forty? I don't know his rank.
Yeah, I'll go, it's Bill 40, and I'll go to the chief on this, but you, in a heartbeat, you'll have them. They've been texting me, so just tell us where and when.
Very good. Thank you. Councillor Marshall?
Thank you, and I'll be repetitive. The chair mentioned, as well as Dr. Yeager, that this has been a work in progress for a long time, and I don't want anybody to think that this hasn't been on the radar. I think that opioid network had as many as 50 different organizations involved, so we're ahead of the game to that extent. But once it's a crisis, it's just a different game, but I just wanted to make that clear.
Okay, thank you, Councillor. In Councillor Diodati's motion here, is there any way that where it says with the agencies out west that we could add Western Canada that have already begun to address? Clerks? Western Canada.
If I could suggest, because my son died out west, I have a little bit of knowledge about what goes on out there. The Portland Hotel Society out west is very, very innovative. I know that we're a lot behind them because they take advantage of the heroin replacement therapies and other replacement therapies as well. But I think that they are an excellent source, and I have a contact that I'm happy to provide that I believe would be very, very helpful in reaching out to.
Okay.
So I can do that and I can reach out to him and find out if he's willing to speak.
And through this motion, you've all been invited now to sit on this Niagara opioid network, so please bring that information.
I will, thank you.
Okay, thank you. Okay, so I will read that the Public Health Department take the lead in consultation with the agencies in Western Canada that have already begun to address the opioid crisis with a coordinated approach with all partners, including but not limited to Niagara Regional Police, Emergency Medical Services, Niagara School Boards, the Niagara Opioid Network, the Moms United, and Mandated to Saving Drug Users, MUMSDU, mental health organizations, and Niagara Health System, with an all-out massive action approach to education, awareness, and investment in addressing prevention and cure strategies for the opioid crisis, and report back to the Niagara Regional Board of Health. If I could I just make a friendly amendment in the fact that we have both the Niagara Health System and the Hamilton Health Sciences in the region of Niagara West. Niagara West is run by Hamilton Health Sciences. Is that okay? To the mover and the seconder? What is it called now, Dr. Yeager? Niagara Health Network? Just Niagara Health, not the system. Take the system out, please, clerk. Okay, and add in Hamilton Health Sciences. Okay, does it look good? Mayor Diodati? Dr. Yeager, does it look? Okay, thank you. Okay. Oh, you're right. Councillor Rigby.
Thank you, Mr. Chair. Just to say that I don't know if the ladies realize it, but you've allowed extensions of discussion, allowed them to stay here, and we made decisions while they're here. We've thrown out all the rules.
I know, and it's wonderful.
We even have people from the gallery talking
well.
with
Thank you very much.
Thank you so much. We knew our 5 minutes was up long ago.
Yeah. All right, see no more questions or comments. I will call the vote. Please, can we have a recorded vote on this?
The vote is open.
He just didn't sign out. Chair Casson didn't sign out, so can we remove that as a no, please? And I believe that's unanimous, 13-0. So thank you so much, ladies, for your presentation.
Thank you so
Councilors,
much.
thank you for participating, and we will move on with our agenda if that's okay. Thank you.
Thank you so much. I do have some additional copies of the presentation. I don't know if you want them or not.
Could you just leave them right
Yeah, I
there,
can
and
do
the
that.
clerks will pick
Yeah.
it up after the committee?
Thank you.
Thank you so much. Appreciate it. Okay, members of the committee, let's move on to 5.1, COM 23, 2017, Ontario Early Years Child and Family Center Plan. A short video will precede the consideration of the report. Can I have a mover to put this on the floor, please? Councillor Quirk, second by Councillor Diodati. Will we show the video first, please?
Through you, Mr. Chair, just to frame this up a bit for the members. The Ministry of Education requires our team to submit a plan for the implementation of the new direction to have the Ontario Early Years Centres, now known as Ontario Early Years Child and Family Centres, to come under our systems management effective January of 2018. Information regarding this transformation of the system has been presented here previously. The plan that is attached to your report, and admittedly is quite lengthy, largely reflects the needs assessment that was conducted by our team, the input from the early years providers, the information with regards to where children live, needs, where the services currently exist, and our plan for bringing that system on. There is sort of an executive summary that's part of the report itself for you, highlighting 3 phases. The first, which you have already endorsed, which is entering into temporary agreements with service providers to bring them on board starting in January. And then the steps that we will go through where we will permanently onboard that sector to our scope of responsibilities. And we have a video with our favorite actor, who, which is going to be public-facing to engage the community in continued dialogue and explain a little bit of the process. So just for your information.
Thank you, Mrs. Judwick, for that background information. Clerks, are we ready? Okay, go ahead.
I want to take a minute to talk about provincially funded child and family programs in Niagara. Niagara's parents and caregivers have access to a wide range of services, supports, and programs that cater to families with children ages 6 and under. These include things like early literacy programs, infant massage programs, and programs designed to support parents and caregivers. Currently, these programs are provided by 3 types of drop-in centers across Niagara: Ontario Early Years Centers, Family Resource Programs, and Parenting and Family Literacy Centers. These drop-in centers are operated by a number of different community agencies. While they're all great resources for families, right now they all have different names and offer different sets of programs. The province of Ontario is looking to build a more cohesive, consistent system to deliver child and family programs across the province. So what does this mean for Niagara? Well, it gives us an opportunity to take a closer look at our current system of child and family programs and ask ourselves things like, what level of access do parents and caregivers have to these programs? Are there gaps we can address? What programs should be offered throughout the region and which can be customized to meet the needs of specific communities? And what resources do we have as a community to deliver these programs? Niagara Region, with feedback from service providers and community organizations, has been tasked with creating a coordinated plan for child and family programs in Niagara. Right now, Niagara Region is undertaking an evidence-based review of all of our current programming, resources, and community needs, and a crucial part of this is community consultation. A survey of parents across Niagara was completed, and that data is being combined with feedback from current service providers as well as other community agencies. We're also taking into account what children value and enjoy about the current programming. All of this information will be used to make it as easy as possible for parents and caregivers to access the programs and services they need. For example, beginning in 2018, those 3 drop-in centers I mentioned earlier will all be called Ontario Early Years Child and Family Centers, offering parents a one-stop shop for child and family programs. Niagara Region will also take a more active role in helping to coordinate and align the many services and programs across the region. While community agencies will oversee the day-to-day operations, Niagara Region will manage the system of Ontario Early Years Child and Family Centers as a whole. The plan for Niagara's Ontario Early Years Child and Family Centers is still in development, and we'll be sharing more details in the coming months about what our future could look like. Visit niagararegion.ca to learn more.
Thank you. Good video. I want to ask one question right from the very beginning. When the Ministry of Education was down here, I want to say sometime in 2016, was that part of that stakeholder consultation where we brought in all of the agencies from across Niagara? Perhaps maybe, do you remember what I'm talking about, Ms. Edgar? It was held in the cafeteria, and the Ministry of Education came down, and I was over 2 or 3 days, and they came down. Is that the same thing?
It's a good thing you have a good memory, because I was having a moment there. Yes, there was some of the discussion around that, okay, for sure.
Just wanted to make sure that was putting them both together. Okay, so we have this now on the floor, duly moved and seconded. Is there any comments or questions about it? The report COM 23-217 dated September 26, 2017, respecting Ontario Early Years Child and Family Centre Plan be received and the following recommendation be approved. 1, that the Ontario Early Years Child and Family Centres OEYCFC's initial plan for Niagara Region attached as Appendix 1 to report COM 23-2017 to be submitted to the Ministry of Education to be endorsed. Comments or questions? Councillor Valpati?
Just to say it's all good news, and I wish them well, because it's going to be a lot of work.
Yes.
Thanks.
That's an understatement, yes.
Yes, I know.
Any other comments or questions? Seeing none, I'll call the vote. All those in favor? And that is carried. Thank you. We'll move on to 5.2, COM 27-2017. This is the approval of the 2016 Long-Term Care Home Audited Annual Reports. Can I have a mover to put that on the floor? Councillor Valpati, seconded by Councillor Beatty. Comments or questions, please? Seeing none, I will call the vote. All those in favor? And that is carried. 5.3, PHD 17-2017, which is the Niagara EMS system design changes. Mover to put that on the floor, please. Councillor Bentley, Councillor Rigby. Any comments or questions? Chief, is this the point in time where you said that there should be something that is clarified or changed? Am I getting that right?
No, sir, through the chair, that would be through the capital report.
Okay, thank you. Sorry, my apologies. Any other comments or questions? Councillor Valpati, please.
Yes, somewhere in the report I read that our real need for ambulance services is around 80%, or something about 80%. No, we were around 20 to 30% of our calls are bona fide ambulance calls. And that the statistic in other regions was that 80% of their calls are bona fide ambulance calls. And I was pleased when I read the report, because I think that what the suggested changes are going to go a long way to change that. But one of the questions I have is, how did we get to be in this mess with our ambulance calls?
Chief, can I have somebody, Councillor D'Angela, could you go and close that door, please? Or somebody? Thank you. Chief?
Great. So through the chair, I perhaps need to explain that stat, because actually that stat actually illustrates that Niagara EMS is doing much better than the rest of the provinces.
And I misread it, I think.
Yeah, if I could explain that a little bit further. The rationalization behind my comment is that when ambulance calls are triaged through a 911 system, the point of the report saying that 70 to 80% of the calls in the rest of the province are triaged as a hot response or a lights and siren response means that they're being over triaged and they're exhausting resources much quicker, because when you have a lights and siren response, you send your very last ambulance because it's highlighted as an emergency. In Niagara, we've been the beneficiaries of using an advanced triage system that in essence has been able to refine that further to a point where in our system, it's actually now 40% of our calls are triaged as lights and siren emergency response, which means that we have greater capacity to hold calls. So 60% of our calls are identified as lower emergency calls, and so we can do more with the system to generate capacity. The point in mentioning those points of data is that even though we're at 40%, which is doing much better than the rest of the province, we believe there's a great opportunity to take that even further, because what we actually see is the 40% of those calls that are triaged as emergency calls, when we arrive, it's only usually about 25% of that 25% that are validated as being time sensitive. So I hope you can follow that. So now we have an opportunity of greater efficiencies to be found within the system. That's what we're proposing to put forward.
I'm really glad I asked the question.
Me too.
Through you, Chair, because I misinterpreted that.
Yeah.
I'm glad that we're doing well and that we have plans to do much better.
Yeah.
And the Wayne Fleet pilot then is one that we're going to be extending throughout the region. Is that true, Chair?
Chief?
So through the chair, not necessarily that the Wayne Fleet, because Wayne Fleet is on its own. Just as a reminder for council, that resource was put in there primarily to respond to emergency calls in an effort to provide that community with enhanced medical presence, pre-hospital presence. As we have capacity within that resource in a rural community, that's where we first ventured into community paramedicine and doing more proactive items as far as going out and visiting with patients. That concept, that theory is really grown within the industry, and particularly here in Niagara, we see that this offers opportunities to spread throughout the rest of the region, which is what we've done. We've now spread that type of a proactive response, if you will, into all areas of the region. We plan to build on that even further upon its success.
Thank you very much for that. And because I know that we have an EMS design expert here, I'd like to ask our CAO if he approves the report and thinks we're heading in the right direction.
It's been a while since he's been the CAO of the
Oh,
EMS,
but
though,
there's some things you never forget.
Sorry, just kidding.
Through you, Chair, to Councillor Volpatti, actually, I can confidently say that due to the work of Chief Kevin Smith, we're quite envious of our other jurisdictions. They like to see what we're doing here. The province has taken notice. A lot of their legislative changes was based on their assessment of what's happening here in EMS. Our Niagara Region EMS is state-of-the-art. Fully support their initiatives.
Well, that's, once again, good news. Thank you very much.
Thank you, Councillor. Councillor Maloney.
Thank you, Mr. Chair. I'm a little confused. This report said financial consideration would require an investment of $813,000, which means certainly more money, but I anticipate the chief's frustration with a lot of 911 calls that are not really valid or bona fide, as my friend has said, and that why would this be costing more money if perhaps we're going to be reducing the number of calls that are 911? And we have three partners in the 911 system. We have fire departments, we have police. And generally in our area, they all show up some sooner than the others. But will this result in perhaps the fire not responding to these calls? Or if EMS is going to have a system where a certain call you want them to be there in 50 minutes, other calls, perhaps 30 would be the standard.
Sure.
And will this end up thin edge of the wedge for more participation by the fire departments, and therefore more resources at the municipal level to fund these calls by our firefighters.
Let's get an answer, Chief.
So through the chair, the reality is that while we have a vision for what we need to do for the future of the system, and it's doing many of the things that you see in the report, some of the things we can do immediately, other things, while we don't want to study, we want to implement because they're the right things to do, take some time, and they take a level of caution because we don't want to create undue risk within the system. We are an emergency service, and we need to be very cautious and certain about how our approach is made. What I can tell you is, as far as tiered responses, we call it, and that's where we have shared responses among our allied agencies, including the fire services and the police service, is what we want to ensure is that we're using those resources in the most prudent way possible, that they are there for the sickest of the patients, and that what it demonstrates that their interaction with these patients has a defined outcome. It changes the outcome of the patient, and that we're not exhausting resources needlessly or without the evidence to support that. So as we move along, we will continue absolutely to rely on partnerships with our allied agencies and police and fire services. What we can do is actually expand upon that and find out ways in which we can better use our resources, from police calls, which are mentioned in there, that we're actually there to support the police services and provide them the support that they need through refined triage processes. And for fire services, that there's alternate ways in which they can help support the system, perhaps through augmented delivery of services within the patients that we see. So if I'm answering your question, absolutely, that will still be part of it. In the interim, to help us get started, the investment in PhD 19, 2017, the information report, speaks to that investment specifically. That request for a program change is going to, as I understand it, the Budget Review Committee for the 2018 budget, but as backgrounder speaks to how we want to use these resources to initiate the changes that we need to see within our organization, within the service we provide.
Thanks, Chief. Thanks for that clarification. I want to go to Dr. Yeager. She wants to talk about a cost clarification, if she could. Dr. Yeager?
Thank you very much, Mr. Chair. And to Councillor Maloney's question about the beginning, and I'm sorry that it was not clear, and I understand your confusion. If you're talking about decreasing call volumes and mitigation strategies, how come you're asking for $813,000? So everything listed on page 3, 4, and the top of 5 are strategies that can be implemented without any input, without any further addition of dollars. They're starting sort of about halfway down page 5 are longer term, broader implication pieces that would almost, if you like, require an investment in order to get better return down the road, but would require an investment of resources up front. But pages 3, 4, and half and 5 can be done without any investment.
Okay. Mr. CAO?
Thank you, Chair. In supplement of what's been said by Dr. Yeager and Chief Smith, I just also want to touch on the topic of 911 service delivery. I've actually initiated a review of our 911 service delivery, and we're working in partnership with police services on what is the best model and how we're delivering our 911 services. So that'll also be part of the equation.
Thank you, sir. Councillor Maloney, you still have the floor. Are you good? Okay, thank you, sir. Councillor Augustine.
Thank you very much, Mr. Chair. I certainly I certainly appreciate and repeat the appreciation that that members of council have for this report. Great work to staff for looking for, as it says in the report, innovative ways to deliver the service, and that's what we've been seeking, and you've delivered. I guess the question I have that's kind of hanging there, and maybe it's just the language, is, and Dr. Yeager alluded to it, Mr. Chair. It says here that the additional services, additional mitigation strategies, short-term without extra resources, may be implemented. So my question is, are they going to be implemented? Can we be bold and say, yes, we're going to do this, because this looks like great work.
Chief, please.
Through the chair. we are tempering our enthusiasm with the realities of the current situation. We are very excited with the vision that is being proposed, and we would like to see all of this and more actually initiated. What we know is that, as Dr. Yeager alluded to, there's items that we can absolutely move forward on right away. I should mention that it does take a bit more consultation with the partners involved, particularly with our allied agencies, with fire and police, as this does change the dynamics of how we respond collectively as mutual agents. But I've had some discussions with them already, and they're both eager to move this forward. So in that effect, absolutely, we're moving forward. Some of the other things that are going to take a little bit longer, most specifically, is how we change our response model to what we traditionally have as our emergency response now, and the low acuity patients as well. Unfortunately for EMS, we're caught in a system where currently we take patients to the hospital to see if they need to go to the hospital. And that's not good service to those that we serve that need care, whether it's health or social services, and it's certainly not a good contributor to the entire health system when we think of the challenges of healthcare delivery. And so what we need to do is work together with our partners to be able to make that happen. One of the big partners are going to be the Ministry of Health and Long-Term Care, the Emergency Health Services branch. I can tell you that we've had initial meetings with senior staff from the ministry, and we've shared this plan with them. They are equally excited to see how they can help move some of this forward. Some of it might require loosening up of some of the legislative changes that restrict our ability to do certain things, but the signal from them at this point is we have full cooperation in wanting to move forward with them collectively. So I'm not sure if that answers your question, Councillor Augustin.
It does, but it opens just a couple more. So of the 4 that are here in this first category that you've identified in the report to say we can do this without extra resources, and you've put an estimate of how you can help the system. The first one, so 911 unknown calls, can that be done? You can just make that change?
So through the chair, yes, that's one of the quick ones we can do. Again, we've already mentioned to police and fire our intent, and it would just be to clean that up a little bit.
So then the same with the police calls response strategies. You probably have to talk to them a little bit, but it's kind of very low hanging fruit, right?
Again, through the chair, we believe that there's already existing process. We just need to go back in and tighten that.
Okay. Lift assist. Small but heavy.
Through the chair, we see this actually as a phase-in approach. The first challenge that is defined within this report is the amount of falls that we have, and this is obviously with a lot of our seniors population, and falls are very debilitating. Quite often what we're finding, and you see with the statistics supplied, is they don't actually have an injury from the fall itself. But what it does is it fails to have an immediate intervention for avoidance of future falls. So we see this as a two-pronged approach. The first is to deal with the fall itself and what resources do we have to assist with falls, and we have other community services and allied agencies that can perhaps help with that from a lift off the floor perspective. From a medical piece, this is kind of the second piece where we use an integrated health discipline approach where perhaps a paramedic is visiting alongside with a physiotherapist to assess the patient for their immediate health needs, and a physiotherapist to intervene in that falls prevention for the future, right in real time.
Great. You know, what I'm getting from this, Mr. Chair, is not that it's kind of a focus on the system or the delivery model. So years ago when these EMS first started, ambulance service, it was just get the ambulance there as quickly as possible and kind of figure out what to do, right? Everything's an emergency. But what we're seeing here is really the innovation and with the patient focus. And so kudos to staff, Mr. Chair, on this. The last one on this, in this area, and then I might have something but just the response plan reconfiguration. Now, this one's a bit more complicated, and I think, Mr. Chair, that's the one where we need to work together, as the chief said, with our partners, with the Ministry of Health. So I guess my question is there something that staff are already working at a staff level on that? Is there something that we can do as the governance body, as the political body, a letter to the minister, a resolution from council, those kind of things that might help and say, we'd ask you to, everybody loves a pilot project, like make Niagara a pilot project on this. And then maybe it'll lead to help those other systems. Mr. Chair, can we hear from the chief on that?
We'll ask him, and if he says that he'll come back and give him a few weeks to think about it, but we'll ask him right now if there's a potential letter of endorsement. Dr. Yeager, do you want to weigh in too as well?
So through the chair.
We could almost sing, we can take the load
Yes.
a bit, but so the answer is yes.
Yes. Through the chair, as I mentioned, we have had discussions with senior staff from the ministry, and they understand our objectives. They recognize actually that Niagara is ripe for this type of, and they don't call it a pilot, they actually call it a template, that this can be a template for the rest of the province. There's a number of initiatives that are happening provincially with, it's a small part of the report where it speaks about the enhancing emergency services in Ontario. It's an effort taking place in Ontario. Part of that is with dispatch reform, but a bigger part of it is the full integration of traditional EMS in this mobile health care environment, and to provide services at all kinds of different levels. And what we presented to them fits within that EESO vision of what the province is looking for. So the fact that a letter to help support this would absolutely be a ringing endorsement to move this forward.
Okay, Dr. Yeager?
Thank you, Mr. Chair. So I don't think it'll be any surprise to this council, but we frequently hear in various venues that Niagara is just the right size. It's big enough to have sophisticated IT staff and a fairly sophisticated infrastructure, but it's small enough that our players know each other by first names and we have connections. We have a very good mix of urban and rural. We also have a little bit of cross-border international thrown in, so it is it's a very good, not a melting pot, but a place in which to work to figure out what's going to work and where the challenges lie.
Thank you. Councillor, you still have the floor.
Thank you very much, Mr. Chair. So I wondered if I might add I don't know if it's friendly or not, but I think it is, just an amendment to say that we would ask staff to put together either a resolution or a letter or something that we can then regional council can endorse. Maybe at our next council meeting or maybe at the next round of committee, whatever. I'd love it at the next council meeting.
Dr.
But if
Yeager,
staff
do you
says
think
they
you can
can't
add
do it,
a letter of endorsement, a number 3 to this motion for the next council meeting?
So through the chair and checking with the clerk, staff can certainly create such a letter within the next couple of days, and if that would be out to council Friday and in time for next council meeting, however, whatever the process is for adding that, we would be happy to provide the letter.
Madam Clerk, is that possible?
just want to add another one, that staff be directed to draft a letter for regional council's consideration regarding
So
not lobbying the province, but encouraging the province to allow us to do the response plan reconfiguration.
So it can come to council in a
So it can
memo
come to
form?
council and with this report, and boom, it goes. I think Mr. Chair, if I can speak to them, if there's a seconder, but just to speak to it, I think what we've heard is it would lend itself not only to the excellent work that our staff are doing, but it would also, and their ongoing activity and liaisons that they have with provincial staff, it also kind of raise it as well, and raise that awareness of what we're doing, give a little bit more bite to what we're doing on this front, and hopefully we can make this happen. We heard, Mr. Chair, that the first 3 in this segment of 4 can be done pretty quickly. It would take some effort, obviously, and you want to get it right. But this other one, the response plan reconfiguration on page 5, will require a little bit of interaction with the province. So I think we should do this and try to build on it and get this happening as quickly as possible.
Can I, is there a seconder for this memo? Councillor Volpatti? Okay. Councillor Gale, as my last speaker.
Thank you, Chair. I want to make sure I understand this 911 unknown calls report. So through you to Chief Smith, my ideal answer I'm looking for is that I'm wrong. But I want to make sure that a person who's got a gun to their head at their house and then the phone goes dead still has, and dials 911, but the phone goes dead. Some people are still coming. I want to make sure that if they're in the water and their last breath, they get 911, the phone goes dead, you're still coming. Yet in this report, it says, and this is the last option. The other option is not to respond to these calls unless a need is validated by police or a patient is confirmed at the scene. The last line of that says, it's staff's intent as approved by our dispatch medical director to implement the latter approach, which would have been that one. So in other words, you aren't coming.
Chief, please clarify.
So through the chair, that is our recommendation. So when you speak about the telephone disconnect, this is where there's true, no voice, no audio, no nothing. And most of these times there are technical issues, a 911 severed line or some other incident. And you can see through the statistics when we looked at 2016, the amount of calls that we went on when there was actually nothing at all that was happening within the system. So further to that, some of the other fire services in the region have adopted this practice as well because of the amount of resources being generated towards it. Currently, what happens, and it's maybe not spelled out in there, is that when we do receive these calls, they're responded to in our middle priority, which is our target is 15-minute response time. So it's not a lights and siren call. We are currently going to these calls out of abundance of caution. And when we get there, we do not enter the scene. We don't do anything until the police arrive because we have no scene verification as far as safety. And safety is always number one with the first responders. And so we wait for the police to arrive. The police come in and do their bit. And as you can see through the statistics, most of the time we are canceled. We're not needed. So when we look at that and we look at the evidence provided and the times that we actually did have a patient interaction and the clinical nature of that patient, there have been no indications where time was of the essence for those patients. So in other words, had we had a system whereby we didn't respond, police arrived, they confirm, yes, there's a patient here, we would respond lights and siren at that time if it was prudent to do so, and then they would get their care. That didn't exist in any of the data that we looked at historically. So the point that you raise is a point that I think when we think about the future consideration of what we're talking about here is the traditional way of responding to calls is going to change. It does create, I don't want to unnecessarily say a heightened risk, but certainly the perception could be that way. But we will still respond when there is a patient identified that needs assistance and medical assistance, and we respond at that point in time.
So Councillor Gill, can I just get some clarification from Dr. Yeager?
Okay, sure. Thanks.
Thank you, Chair. And it may be clear, but I just want to reassure that the police are still going. So when Chief Smith says we, right, the 911 dead air, and there's a gun to my head, as you say, and so the police are still coming.
Oh, okay.
So, and what he's saying is that always in these calls, it's the police who count the most because they're going to go in first. And they're going to assess the situation.
Okay, then I read that wrong.
If it's a medical situation, they will call them. A lot of the time, it's not. Right? I can take the gun down.
You effectively shut me down for the right reasons. Thank you. I thought that no one was going, and so thank you.
So the we does not apply to all three services. It just applies to
I'm good with that. Thank you.
1 second, Councillor Gill. Chief.
I think Dr. Yeager answered it adequately. I just wanted to reassure that in the scenario being given, if we can hear things in the background, we're going, it's when there's a call disconnect.
And that's common sense,
There's
but
that,
what
yes.
Dr. Yeager just said solves it for me. Thank you.
Okay. I see a hand up, Councillor Volpatti.
Thank you for allowing this. Just one quick question. Does the proposed realignment of the health regions affect the EMS service?
Are you talking about the sublens that have been proposed?
Correct.
Dr. Yeager?
Through you, Chair, so clarification, please, the subregions or the expert panel in public health?
No, the subregions.
The subregions. There has been no mention either through any of our channels that we've heard of any proposed changes to EMS.
Okay, thank you.
Okay, good question. Okay, seeing no other comments or questions, I will first talk about the amended by adding the following recommendation, and then I'll go back to 1 and 2. The amended is that staff be directed to prepare a letter for council's endorsement to encourage the province to allow Niagara Region to develop a response plan reconfiguration, and the letter be presented at the Niagara Regional Council meeting to be held on October 5th, 2017. That is an amendment that is put forward by Councillor Augustine and second by, I can't remember, Councillor Volpatti. Seeing no more comments or questions, I'll call the vote. All those in favor? That is carried. Now, clerks, if you could please put up number 1 and 2 for me. The whole motion as amended, but I just wanted to read it out. That 1, that Niagara Region Public Health the Niagara Region Public Health performance achievements for the 2016 Accountability Agreement, Health Protection, and Health Promotion indicators be received, and 2,
One ahead.
sorry, here we go again. The report PhD 2017 dated September 26, 2017, respecting Niagara EMS system design changes be received and the following recommendations be approved. 1, the council received for information the service delivery changes described within report PhD 2017 as part of the transition towards a mobile integrated healthcare system, otherwise known as MIH, previously endorsed by Regional Council. And 2, the staff be directed to deliver a more detailed service delivery design report in Q4 of 2018, including an alternative model, long-term resource plan, and implementation strategies to achieve the future model. Any questions or comments about 1 or 2? Seeing none, I will call the vote. All those in favor? And that is carried. Thank you. Clerks, am I good? Thank you. Okay, we'll move on to 5.4 MOH 04-217, accountability indicators. Kind of a mover to put that on the floor. Councillor D'Angela and Councillor Marshall, comments or questions? I see none. That report MOH 04-217 dated September 26, 2017, respecting accountability indicators be received and the following recommendations be approved. 1, that the Niagara Region Public Health NRPH performance achievements for the 2016 Accountability Agreement Health Protection and Health Promotion indicators be received, and 2, that the performance targets set by the Ministry of Health and Long-Term Care for the 2017 Accountability Agreement, Health Protection, and Health Promotion indicators be approved. Questions or comments? Councillor Rigby.
Yes, Mr. Chair, I've noticed that there's a slight difference in the way we're handling. Is this a new procedure, reading the bylaws out, motions out? Is that something new that we're doing?
Just something I like to do.
Oh, it's the way you do?
Yeah.
Okay, thank you.
Is that good? Okay. Any questions or comments? Seeing none, I'll call the vote. All those in favor? And that's passed. Okay, is there any members who wish to separate any consent items or have any questions on the consent items? Move them all in block, 6.1, 6.2, 3, 4, and 5. Moved by Councillor Volpatti, second by Councillor Maloney. Any comments or questions? Councillor Volpatti.
Just a brief question, particularly on 6.5 Niagara Regional Housing. I'm assuming this is a the budget preview, that if we have any questions, we can address them directly to the director at our leisure.
Being the director of Niagara Regional Housing.
Correct.
Yes, absolutely.
Okay, thank you.
Okay. Councillor Augustine?
Well, I think Mr.
Hold on.
Troke, I assumed.
Hold it.
Well, I'm sorry.
So I think I knew what you meant. Yes, thanks for
Yeah,
your
as long as
clarification.
people know what I meant, it's a good thing.
Guys, hold on a sec. I understand that Councillor Volpatti used the wrong terminology, but I understood what she meant, okay? And I couldn't just quite think of the gentleman's name off the top of my head. What is his official title, please?
I believe he's the CEO, and his name is Mr. Dan Troke.
Thank you.
Thank
That's
you.
who you meant, right, Councillor?
That's who I meant.
Okay, very good. Now, move on to Councillor Augustine.
Thank you very much, Mr. Chair. You had said earlier that there was going to be a change or clarification on something with EMS and the capital budget. Thanks.
Yes, you heard well, Councillor. 6.2, PHD 18, 2017, 2018 capital budget review for public health and EMS. Chief, would you just like to clarify something there, please?
So through the chair, that item has actually been removed from capital. It will actually be moved into a business case for program change, as it is more to do with operating than a capital investment.
Okay. Thank you. Thank you. Thank you for remembering that. Any other comments or questions? Okay. Did I get a mover for that, for the consent? I did? Okay. All those in favor? And that is carried. Thank you. Other business, are there any items of other business at this time? Seeing none, Madam Clerk, closed session. There are no closed session items. Next meeting. The next meeting will be held on Tuesday, October 17th, 2017 at 1 p.m. in the Council Chamber Regional Headquarters. There being no further business, this meeting is now adjourned at the hour of 3 o'clock exactly.